Sit down. That's why dear friends, human speech is okay for you. 3 times I asked. One time I came at 2 o'clock, told if you are here, be silent. Then after you, I got a call that your students are not behaving properly. I should swear everywhere that I called them at 2:30. And okay, I am here, still you are doing the same. I imagine what happens if I am not here. About yellow and so on, we're finished.
Yes.
Murmurs, initial part we have done, I think.
Yes.
So, today we should speak about exact murmurs. Look, murmurs once more appear if we have these 3 conditions: blood velocity increase, changing blood diameter of a vessel or valve orifice. In other words, if blood is flowing from large parts up to a narrower part, or from a narrower part into a larger part. Telling narrower or larger, why do we group leaders? Just now give names of absentees, afterwards you'll forget them those. I mean pathologically narrow, because anyway, blood circulation system, aorta, large, mid-diameter arteries, small diameter arteries, arterioles, anyway is going to be smaller. But, for example, aortic stenosis already is pathological decrease in the diameter of human. Viscosity decrease, for example, in anemia, so the chance of turbulence increases. This, you know, classification of cardiac murmurs we may do by cardiac cycle, by intensity by Levin-Freeman. Freeman's classifications by cardiac cycle. I told we made diastolic, systolic, systolic, diastolic, murmur. And also they have subphases. For example, maybe early diastolic, late systolic, mid systolic, taking the whole systole, which means holo or pen diastolic or pen systolic. Also, we have this classification. More exactly, it is classification of murmurs of precordial region, which appear in precordial region. According to this, we may have intra and extracardiac murmurs. Extra means out of heart chambers here. For example, pericardial friction rub, very typical for dry pericarditis, appears here. It is very much similar to pleural friction rub. There was dry pleuritis, here is dry pericarditis. Today, if you have time, we'll speak about this. If not, we can start. PDA, pater ductus arteriosus.
Yes.
So open arterial duct.
Duct.
Open. Intracardiac, extracardiac, yes. Murmurs and intracardiac, maybe organic. Here, organic, I don't think that we may have non-organic. Here, structural. Just I have translated from Russian, there is called organic. In Armenian also it's organic. Organic means not only organic, inorganic, but also organic and structural. So structural and functional. In functional murmurs, we have pure or instantly functional murmurs and so-called innocent murmurs. The term innocent emphasizes that we have no serious underlying cardiac pathology. For example, in anemia. Anemia itself, which is a classical innocent murmur, is functional murmur. Heart there is not impaired, heart structure. But anemia may be even, not always, but maybe even so much severe that the patient may die. So itself it's not an innocent thing at all. But it's innocent from the point of view of cardiovascular system because anemia is a hematological disorder, not cardiovascular system. That's why innocent in parastasis means that we deal with non-serious cardiac underlying cause. Structural murmurs in their turn may be ejection, for example in aortic stenosis, and regurgitant, like in mitral regurgitation. About abbreviations, if we have not spoken, I'll tell. Look, we have usually murmurs are very much typical for valvular heart disease. Here it is. Valvular heart disease means we have problems with valves, but they may be, but though not only valves. So we may have acquired heart defects and congenital. Congenital may be, for example, the same pattern, ductus arteriosus, tetralogy of Fowler,
Yes.
and so on. Or ASD, VSD, a lot of total abnormal venous return of pulmonary veins, which are drained into left atrium but partly into the right atrium, and so on. PFO, patent foraminovalle. Mainly we'll speak about acquired. Acquired are mitral regurgitation, tricuspid regurgitation, mitral stenosis. These abbreviations I will use because they're real. Aortic stenosis and aortic regurgitation. As for tricuspid stenosis, it is very rare and mostly congenital, so we will not speak about them. And for pulmonic stenosis, also is congenital. It's a part of tetralogy of Fowler. Also, number 4 is pulmonic stenosis. So again, we will not speak. Tricuspid regurgitation, yes. So these 5 mainly we'll speak about them, and as much as it concerns to the murmurs, yes, because other congenital heart defects are very complex defects very often. I don't want to tell you, there is a TGA, transposition of great arteries, core TGA, corrected TGA, went from left side. TGA went from the left ventricle starts pulmonary trunk, and from the right ventricle aorta. It is TGA. Corrected TGA, that everything starts from its place, but on the left side is structurally right ventricle. And so on. So imagine how complex will be these murmurs. And so it's pediatric cardiology. It's a specialty. Something superficially, I'll tell you, I'm not also a specialist there. I don't have this experience in these defects. Yes, I had a cycle of 3 months during my residency, but anyway. So, mainly we'll speak about this, and speaking about these murmurs, structural murmurs, we'll start from organic murmurs, like from this. Where is it? Ejection murmurs and so on. More exactly, I'll start from here. by cardiac cycle, systolic murmurs. This is a way usually, doesn't matter, we may start from functional murmurs, but anyway, practice has shown that it's better to start as we are starting. Students are memorizing more easily. So, systolic murmurs. I'm telling you now classical systolic murmurs and classical diastolic murmurs. Classical systolic murmurs are these. For example, mid systolic ejection murmur, middle part of systole, typical for aortic stenosis. Hollow or pensystolic. Typical for mitral regurgitation. And late or end systolic. Typical for mitral valve prolapse. As soon as valves are in pairs, one pair is AV valve, AV valves are, another pair are semi-lunar valves, and they open and close at least more or less simultaneously at the same time. So, if murmur is systolic in case of aortic stenosis, it will be also in pulmonic stenosis. If, for example, in mitral stenosis of diastolic murmur, it will be diastolic also in tricuspid stenosis. Mitral tricuspid, aortic pulmonary. So here aortic stenosis also we may say that in pulmonic stenosis, but it is congenital defect. Usually we are not speaking of mitral regurgitation. The same is in tricuspid regurgitation. Mitral valve prolapse also tricuspid valve prolapse. Site of auscultation will be another. But this is rare. We will not speak about this as well. Okay. These are classical systolic murmurs, diastolic murmurs. Okay, for not losing time. Diastolic murmurs. We have early diastolic or protodiastolic, let's say. Typical for aortic regurgitation. You understand, also for pulmonic regurgitation. Hollow or pendiastolic. Hollow or pendiastolic, distance for diastolic. Typical for the same aortic regurgitation, which is more severe. Then we have two other murmurs. We have mid-diastolic, which in Russian textbooks is called late protodiastolic, but it's the same. And pre-systolic. The cause of these last two is mitral stenosis. The cause of these first two is aortic regurgitation. But in that case, it was more severe. In mitral stenosis, both are present usually. You may take a photo, you may write down, I don't know, make notes because we are going forward. Group leaders, absentees. 303, 304. Tomorrow you don't have a lecture. Because today we have. I have to tell letter by letter because I changed the time for 6th-year students. I thought come at afternoon, not at 9:30. They told yes, and some people appeared at 9:30. Just today. May I go to another place? Now, one by one, and trying to describe the murmur. Mid-systolic ejection murmur. Mid-systolic ejection murmur. Cause of which is aortic stenosis. Aortic stenosis. Now let's understand how it appears, and then it's. also remember that we have this. While describing the murmur, we pay attention to these circumstances. Now we'll try, not always it's possible, not always, not everywhere, not all murmurs. I mean about each characteristic, but these first 3-4 should be done. Timing means when, in systole or in diastole. Duration means in which part of systole or diastole. Site of auscultation is clear. Made radiate, if yes, yes to where. Shape, it is coming from phonocardiography. And for pitch and quality and intensity already you give. Intensity, for example, I'm telling I can 3 out of 6. 4 out of 6 if systolic, or 2 out of 4 if diastolic. Now, knowing this, have this in mind, keep this in mind, and let's go forward. Murmur in aortic stenosis. You should be able to explain why murmur appears. The cause of all murmurs is what? No. Cause of all murmurs. Oh my God. You will fail. Turbulent blood flow, my friends. 1 week has passed since I told you. Up to exam will pass 1 month and more. What are you going to do? Huh? Cardiac murmurs. Here I should. Cause of cardiac murmurs is turbulent blood flow, which appears in these cases. Now, aortic valve area, surface of aortic valve, if we try to measure normally, it is approximately 3 centimeters square. It's normal standard value. When it is becoming less than 1 or less than 1.5, we have already more or less significant stenosis. Less than 1 is very significant, very less than 0.75, critical stenosis, and so on. Now look, we have diameter change. Blood is coming from a larger part to a normally narrow part. It is leading to turbulent blood flow, and thus a murmur. Also, it is one factor. While passing, it's ejection murmur, typical ejection murmur, I have written. Mid-systolic ejection murmur. While passing through the aortic valve, it is difficult, yes. So blood flow velocity is increased. And velocity increase is another factor of turbulence. So you have 2 factors at the same time. And remember this equation. Pressure gradient is equal to 4 times velocity in square. Very often in clinical practice, this is how we determine surface of aortic valve. Using this, it is called Bernoulli's formula. Pressure gradient is directly proportional to the square of velocity. 4 is constant. A bit later we'll speak about this. Though why later? Let's speak now. Look, this is aortic valve. By the way, one of the positions should allow you, in next year you will see, to reveal that it really has 3 cusps, because I told you, maybe bicuspid valve. But anyway, it's called planimetric version. To measure surface is difficult. Not always we have good visualization for surface measurements, for accurate measurements. Instead is used this formula, delta P is equal to 4 times velocity E squared. For this, what is used? Look. We have, echocardiography, then bimodal Doppler. Doppler is for flows. So we are trying to catch transaortic flow and measure it. As far as transducer, one of the positions, is placed over the apex. Yes. blood flow is away from it in aorta because it's opposite side. Here is transducer, here is your blood flow. If it be towards, we'll have positive flow. It's like negative flow below the baseline, like this. We see this, and so on. It is corresponding to systole. This is diastole. Because in systole we have transaortic flow. It is normal. And here we have scale, like 1, 0, 1, 2, 3, 4, and so on. Meter in second. It's velocity. Modern devices directly measure using this formula. But all devices where we are putting here on the peak, on the top, we can get, for example, how much is the velocity, and by multiplication, we can get how much is the gradient. Now, normally, Hello? What is this? Are you? For you. One task is to find electrodes because it's very hot there. Only for this, but you have, where is it? Okay. But try to, look, if today is hot, okay, I understand. Tomorrow you are a doctor. It's hot, you come in your casual format. Yes, sister. Normally velocity, average values I have, is 1.5 meter in second. Measure delta P. Delta P1 is equal to 4 times 1.5 in squares. How much is it? You may calculate.
4.
At least approximately you understand how much.
5.
Square of 1.5 is 1.5 times 1.5. So it's altogether 4 times 1.5 is 9. Okay, let it be approximately 10. Look, we are doing what? We know that if gradient is less than 16, it's not stenotic. We are measuring gradient. By this we can judge about the surface. Now I'll tell you, in case of severe stenosis, velocity is becoming 4 meters in a second. 4 meters in a second, which means that delta P in aortic stenosis, it was normal. 4 times 4 in square, 4 times 60, 64, yes? If gradient is above 50, it's already indicating severe stenosis, which means that there are special tables. But approximately I'm telling you that surface is less than 1 centimeter in square. So by measuring pressure gradient, we can judge about the surface. But today I would like to show you that when surface is becoming narrow, velocity is increased. If we try all together to run out of the door, we'll have turbulent students and teachers may be flowing. What is left from the students and teachers? Something bloody. 3, 4 will pass, but those will pass rapidly. This is what I mean. The same happens there, but instead of us are RBCs. Was clear? It's yours? Who's it? Now let's come back to the previous talk, aortic stenosis. So we realized that when in English language it's written across the valve. Across the valve. It is across the valve. Narrow valve. Across the narrow valve, when we have blood flow, it is leading to turbulence and thus flow, thus to murmur. When you will be asked, it is third year, maybe you will be asked not how to determine aortic stenosis, I mean this pressure gradient and so on. You will be asked why murmur. Why mechanism is this? Anywhere you tell that mechanism is turbulent blood flow, you are not mistaken. Yes, I swear every time it is turbulent blood flow, but this is how we know for this moment. But how this turbulence appears, you should tell. Because for example in anemia it happens due to viscosity decrease. In case of stenosis, speed increase and valve surface decrease and so on. This turbulence now, when we have blood flow from left ventricle into aorta, this is which phase? Ejection phase. Systole, but more exact. So that's why it's not starting just here, because this is what? It's very sensitive. It is isovolumetric contraction phase, because there appear S1 and S1, mitral tricuspid closure. So it starts after the ejection. Look, murmur looks like this, even, I'd like to draw it like this. It is from phonocardiography. So, at first pressure gradient is increased, because we have rapid and slow ejection phase. It is increased, then pressure in aorta rises, and in left ventricle decreases as in normal. Thus, pressure gradient is decreased. Accordingly, murmur turbulence is becoming less, and murmur is becoming less in intensity. So remember this. It is called crescendo decrescendo murmur. Why? Because these musical terms are taken from Italian. It is written, those who have gone to musical schools. Crescendo, this is part, increase, and decrescendo is this part. Or diminuendo. In Italian it means gradually decrease. Crescendo means gradually increase. Which means that murmur doesn't have the same intensity during its whole period. It's crescendo, decrescendo, murmur. Okay, increasing, decreasing manner intensity, increasing, decreasing character. This is S1. Next S1. Just by this, I'd like to show that here is diastole, here is systole. Yes, this is systole, and this is diastole. Now, memorizing the previous, just for me not to go over these characters of the murmur, describing the murmur. So, timing, duration, so on. So, you may write down, it's mid-systolic ejection murmur. When you are telling ejection, you are already telling also mechanism. So, in ejection phase, this I'll tell, then you may continue. When blood is trying to leave the ventricle, it has difficulties. Because instead of 3 centimeters squared, it has 1. And it is increasing blood flow velocity, and change in diameter leads to turbulence. To be honest, it's the same, because they coincide, these two factors, both decreasing diameter and velocity increase. So it's mid-systolic ejection murmur, so timing and duration we call it. Site of auscultation, aortic valve area, second intercostal space from the right, yes. More correctly, it is right sternal border. More correctly, it is right sternal line, because parasternal is between sternal and mid-clavicular. Or right sternal border. Usually in English I use borders. Next question is, may it radiate? If yes, to where? Yes, it may radiate. Radiates is spray, murmur. Sounds cannot radiate. Why? Because turbulence may radiate with the blood flow. So it may radiate, which means it also may not radiate. It's not a criteria, but we are checking. It may radiate to carotid artery region, to the neck. How to check this? As an example, I told you. We ask the patient to tilt the head and hold the breath for a while. by tilting the head, artery is becoming more superficial. And in carotid triangle, we may easily find it, though we may palpate that place. And not to breathe because there is trachea. And tracheal sounds, this laryngeal tracheal breathing, bronchial breathing, will interrupt this murmur. We are doing this on both sides. In some textbooks, it's written that to the left, not mandatory, maybe to the left, to the right, to both sides, maybe to one part, because it's turbulence. Next is what? Shape of the murmur. It is rhomboid shape or diamond shaped murmur. It's rhombus. Crescendo, the crescendo murmur, it is also coming about the shape. Then is coming what? Character, pitch, quality, yes? It is a rough murmur, has scratching character. Yes, that's something scratching. I've translated from Armenian, I don't know what scratching. And the last one is intensity. Intensity already Levy-Freeman, depends upon a patient. For example, maybe 2 out of 6. By the way, we are using both Arabic numerals or Roman numerals. For example, maybe 2 out of 6. Which means 6 grading system and exactly 3rd in this case. If will appear, for example, also thrill will be 4th, at least. 4th, 5th, and 6th is when we are listening this without stethoscope. Distant murmur. Was clear. A bit more slowly was this one, but on this basis others will describe. So second murmur here is holosystolic or pansystolic. I told these 2 prefixes are coming, one from Latin language, another from ancient Greek language. Pan, holo. Both means hollow, 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 hollow. So the holosystolic murmur, yes? Here we don't have smart option. Holosystolic. For me to write, I need to bring to typewriter. No? Holosystolic murmur. So holosystolic murmur. Holosystolic murmur. Classical in mitral regurgitation and in tricuspid regurgitation. Now let's speak a bit about mitral regurgitation. About tricuspid, I'll tell details. So, first, second, S1 and S2 is the same. And this is next S1. So, let's understand what happens. Again, we are coming back to cardiac cycle. You want, you don't want, I want or not. We have to concern to this. Because all sounds and all murmurs appear due to cardiac cycle. Very simply, if we will have asystole, no sounds and no murmurs will listen. By the way, it's one of the options for confirmation of biological death. When you place the stethoscope, and you don't listen any sound, or to start CPR. With the same success, you may place transducer of echocardiogram and see that there is no contraction, no relaxation. To confirm that yes, heart is not beating. But not always you have transducer, but auscultation is more available. Now, mitral regurgitation, it means incompetent closure, yes, lacking closure. If, I told you, if valve is failing to close, it's called incompetence, insufficiency, or regurgitation. Mitral regurgitation means that during systole, part of the blood will appear from left ventricle back into the left atrium. Because look what should happen. Asynchronous contraction phase, nothing special. Isovolumetric contraction phase, mitral valve lifted should come to this position and close hermetically. And that's all. Then further increase in blood pressure should lead to opening of semilunar valves, in this case aortic, and we should have ejection. Now look, they are coming, but there is a space. For some reasons, for example, imagine rheumatic fever. These leaflets are inflamed, are shrinked, and we have some space. This is how it happens. So from left ventricle into left atrium during systole, start of systole, all this is here, S1. By the way, S1 is soft. S1 is soft because we have non-hermetical closure. I told that we have factors. I think next time I'll speak about this. Factors influencing S1 and S2. We spoke about this. No, these are components. But which factors play a role? One of the factors is how hermetically are closed AV valves. If there is a space, it's not non-hermetic closure or non-hermetical closure, and blood is going from left ventricle into the left atrium. So if there is a space, turbulence, yes, appears in unusual space. Should not be, should close. Turbulence and dust flow, and dust murmur. Now turbulence will appear when? In isovolumetric contraction phase, but during ejection phase, this space also is not disappearing. So it takes the whole system. Because I thought asynchronous phase we neglect, on-oscillatation I mean. And more or less, so what happens in ejection phase? Part of the blood will go anterogradely from left atrium to aorta, as it should be. Part retrogradely to the left atrium. Even we have fraction of regurgitation, it means that how much of this ejection is going on regurgitation. Of course, as you understand, systemic circulation is lacking in blood flow. So part of the blood is in left atrium. I don't want today to speak about hemodynamic other changes. Look, but one thing I'll tell. Remember these pathophysiological changes. If any chamber of heart out of 4 chambers is undergoing volume overload, pathophysiological response is dilation or dilatation. I don't know, you have native speakers in English maybe. There is some difference between the dilation and dilatation. Like one is more passive, one is more active process. Okay, I'm using the word dilation. Okay, I'm not a native speaker, so please forgive me. Dilation. If any chamber is undergoing pressure overload, pathophysiological response is hypertrophy. Okay, volume overload, dilation, pressure overload, hypertrophy. If both, maybe yes, the chamber is undergoing volume and pressure overload. So look, if we have only hypertrophy, it is called concentric hypertrophy. Concentric, which means only wall thickness is increased. If size of the ventricles or atria is enlarged, it's called dilation. Pay attention, for atria we are using the term enlargement. For ventricles we are using the word hypertrophy in English. In Armenia is the same. We are talking hypertrophy of left atrium. Why? Because atria don't have so thick walls as ventricles. So for them dilation hypertrophy is more or less the same. Enlargement cannot stand too long. Afterwards will dilate. But for example, left ventricle may be only dilated. It is called dilation or dilatation. Maybe hypertrophy. It's called concentric hypertrophy. If both, look, hypertrophy plus dilation is called eccentric hypertrophy. Now look what happens during the time. Left atrium. Well, I'm speaking about chronic mitral regurgitation because we have acute in short period of time. Acute, you know when maybe. For example, if we have rupture of chorda tendinea or capillary muscle, or it may be in myocardial infarction as acute phase complication. It may be not due to ischemia of capillary muscles again in myocardial infarction. That's why after PCI, you may see that 4th degree regurgitation became first because blood flow is restored. In case of acute left atrium, it doesn't have time to dilate. It's a more severe condition. So this extra blood flow, it will take and send to the pulmonic veins and to the pulmonary circulation, As a result, pressure is increased there, and we may have pulmonary edema. Patient may die of pulmonary edema. May not die, but pulmonary edema may not have. If we have chronic, pulmonary edema also is possible, but left atrium is dilated. So due to volume overload. Remember this, because afterwards mitral stenosis, mitral regurgitation are resulting in pulmonary hypertension, which leads already to right ventricular hypertrophy. So left-sided disease led to right ventricular afterwards failure, but the first hypertrophy dilation. And another term, cor pulmonale, pulmonary heart. Remember or write down because we'll deal with it. Cor pulmonale means hypertrophy and or dilation. It is coming from American English, from their definitions, and or. Very interesting. And or means either or and both end. So it's right ventricular hypertrophy nowadays and or right ventricular dilation due to pulmonary hypertension, which in its turn is due to any problem in pulmonary circulation. So the cause of pulmonary hypertension should be somewhere in pulmonary circulation, so it should be due to lungs. Mitral stenosis, mitral regurgitation, if are resulting in right ventricular hypertrophy, dilation, right ventricular failure, it's possible. But it's not possible. It is very common, but it's not called cor pulmonale because left-sided heart disease led to right-sided problem. Meanwhile, pulmonary problem should lead to right ventricular hypertrophy or dilation to be called as cor pulmonale. Cor pulmonale, which means literally pulmonary heart. But hypertension is present in all cases. We have acute cor pulmonale because it's a variant of right ventricular heart failure also. We have acute and chronic. The most common cause of chronic is COPD. We spoke about this. That's why in COPD we saw edema, which is due to right ventricular heart failure. The most common cause of acute is pulmonary embolism. You may write down this because anyway during the semester more or less we'll deal with this. Today or tomorrow I'll try to send you a bit more updated version of the lecture I have sent. I'm working on this. The last slide. Lecture about sounds, murmurs and so on. To go to already pathologists. Now, it was just by the way, it's not here. So as we understand, as we have understood already, we'll have continuous flow during the whole systole. So it's hollow systolic murmur. Now let's describe. It's systolic murmur, more exactly hollow systolic murmur. Size of auscultation is mitral valve area or apex. May it radiate? Yes, it may radiate, it may not radiate. But when it radiates to the left axillary region. Because when the apex is here, left axillary region. Per continuation. It is turbulence is going there. Then it's look, it is regurgitant murmur, not stenotic. Stenotics is softer in comparison to that one. And intensity already you know depends upon the situation. That's all. Shape. Rectangle shape. Rectangle shape murmur. Sometimes when we have very severe mitral regurgitation, we may listen like this. Murmur, pause. Murmur, pause. Not sound, murmur, sound, pause. S1, murmur, S2. Which means that murmur was so strong that was fused with the S1 and S2 or has absorbed the sounds. Here, murmur will correspond to systole and pause to diastole. You remember I told before we started that last time. To listen a sound means to to listen start and end of the sound. Now here it is fused, for example. This is S1, S2. Yes, I may draw like this, but very often we have this fusion. And we listen murmur, sound, and murmur, pause, murmur, pause. This is what concerns to mitral regurgitation. Tricuspid regurgitation, all other characteristics is the same, but site is at the base of xiphoid process because it's tricuspid valve area. But there is one interesting phenomenon. When we ask the patient to perform deep inspiration, in case of tricuspid regurgitation, murmur intensity increases. Why? Because on deep inspiration, venous return to the right part. The heart is increased. Intrathoracic resonance pressure is decreased. Like this sucking potential of the heart from the vessels vena cava superior, there is more. So more blood is going through the vena cava superior to the right atrium. In diastole, more blood will come from right atrium into the right ventricle. In systole, accordingly, more blood, more regurgitant flow will have. The chance of regurgitation is more. This phenomenon is called Rivero-Orvalos phenomenon. Rivero. This is when we ask the patient to perform deep inspiration. Due to the above mentioned factors, murmur intensity is increased. It's typical for tricuspid regurgitation. Tricuspid regurgitation is very common in clinical practice. Very often it is functional. By the way, it's functional or organic structures, doesn't matter. Just functionals are softer. But if it is systolic, it is systolic. So holosystolic, holosystolic. Next was end or late systolic murmur. The common cause for this is mitral valve problems. This is S1, this is S2. What is mitral valve prolapse? Prolapsing is the following. Look, mitral valve leaflets, optionally, let's say, not normally, because mitral valve prolapse even may be a variant of norm only is considered. It's like this, closure. But sometimes, let's imagine that one of them, usually it is arterial leaflet, which is close to interventional septum, is longer, like this. So, when it is coming to closure, it is flexing into the cavity, this is called prolapsing. This process is called prolapsing of anterior valve of mitral valve into the left atrial cavity. More correct name is this. Whole name is this. Prolapsing of anterior or posterior or both leaflets is possible, but most common is anterior into the left atrial cavity. Process is called prolapsing. Prolapse. Like drop. Okay, but when it happens, space appears at the end of systole. So it's a partial variant of mitral regurgitation. Imagine, but how you can imagine if I am not wrong? For example, heart normally is not green, of course. Imagine that on closure, wait, this one is like this. This is prolapsing. This is anterior leaflet. But we have regurgitant flow from left ventricular cavity into the left atrial cavity. It's mitral regurgitation. Accordingly, murmur. Murmur is heard over the mitral valve area and is not spread. Though in FMG textbooks it is written that it is spread to the left axillary region. But less likely because it's end of systole. Look, when it happens, it cannot be at the start because we have closure, ejection phase. At the end of systole, close to S2, when treated, here it appears like this. And it appears after this. It is so-called mid-systolic click. You remember, we have in extra sounds, mid-systolic click. So, mid-systolic click corresponds to this moment. This flexing is leading to mid-systolic click. It is typical auscultatory picture of mitral valve prolapse. Now, if all of us will undergo echocardiography, maybe half of us will have mitral valve prolapse. But depends which degree. Even it's a variant of norm. Like valve is more flexible. But it may indicate also serious diseases like Marfan's syndrome, Dillard-Enlo's syndrome, and so on, when we have problems with connective tissue. Maybe part of it. Here question not only in prolapse, because prolapse also has degrees on echocardiography. How many millimeters is away from this plane, 0, from this 0. Up to 3 millimeters, 3 to 6, more than 9, for example, 30. And very important is how much is the regurgitation, because your mitral valve prolapse may be second degree, but regurgitation first. So severity is on regurgitation. Then surgical repair also is about this. But usually, if it is first degree its own, it's not requiring any treatment. Just we may have typical two features with systolic click with, and systolic murmur. With and systolic or late systolic murmur. Very often they are described together. This is typical auscultatory picture of mitral valve prolapse. With the same success, we may have tricuspid valve prolapse, but it is rare. We may have that both leaflets are prolapsing, but we are speaking about this situation. Yes, will appear space, we'll have mitral regurgitation. Systolic murmurs are over, diastolic murmurs. Diastolic murmur first was early diastolic or protodiastolic murmur. Cause was aortic regurgitation or pulmonic regurgitation. This is S1, this is S2, this is next S1. So murmur should appear here. Mechanism of the murmur, then we will describe. Murmur is like this. Appears due to what? When transaortic flow after ejection phase appears in aorta, then pressure gradient is changing the direction. Now pressure in aorta is higher than pressure in left ventricle. And due to pressure gradient change, it is trying to come back to the left ventricle. On its way is meeting aortic valve leaflets. Look, we're open in this direction. Now backflow is in these pockets, and we have closure. This closure is associated with S2. Now, first of all, S2 will be soft because we have no hermetical closure, by the way. S2 depends upon how hermetically are closed semilunar valves in protodiastole or in early diastole. And second, when trying to pass through these valves, yes, abnormal space appears. Nerve should come and close. Now it is passing through this space. It is leading to turbulent blood flow and thus murmur. Pressure gradient decreases, accordingly murmur intensity decreases. It is decrescendo murmur. So let's describe by these points. So it's early diastolic or protodiastolic murmur. So diastolic, early diastolic. Site of auscultation, aortic valve area. Murmur is spread to the apical region because where is apex? It's left ventricle. Left ventricle is forming the apex. It is towards there. So it is heard also, and sometimes very well, about the Erb's point. Here, for what Erb's point was used. Because I'm afraid to open and show you to go back so much, many slides. Here was aortic valve area. Here is apex. Okay, I know here. Regurgitated flow is like this. Erb's point is somewhere here, third or fourth, because stays in your left or third by left sternal border. So this turbulence is even severe here. Maybe over the aortic valve area you will not listen, but over the Erb's point you may listen better. Look, murmur may be heard in about all 5 points, but I mean, the same is for aortic stenosis. We may listen or for other, not only there. But there is bed which corresponds to the valve is higher, of course. And here is the case. So it may be heard over the apex, maybe over the aortic valve area, but it is heard over the Erb's point. If you remember, I told that ERF point is differential diagnostic point, the meaning of which sometimes to distinguish murmur release is due to mitral or aortic valve problem. Because in case of mitral regurgitation, also over the apex. Murmur, which is spread to the left extremity. So, yes, it's diastolic, but anyway. There are functional murmurs as well. So, site of auscultation, we spoke. Shape, appearance. It is decrescendo murmur. We make a triangle shape, but okay, decrescendo, it's decreasing murmur. And it's soft in quality, in character. As a rule, diastolic murmurs are softer than systolic because the chance of turbulence in total is less. Next, you have somebody has USB stick. Now, if somebody has after the lecture, come with me in 403. I'll give you this program simulator for sounds and murmurs. There is introductory part like text. There is animation which is showing what I'm telling, and there is also auscultation. You may listen, but it is working only on Windows, on iPhones, iPads, iOS systems is not working. By the way, when it appeared, I think iOS was not. It was in 2003. Or just started. This one is good. Was clear. The second murmur, hollow diastolic or pendiastolic, this is the same, but if, like here I'll draw like number one, yes? One for diastolic murmurs. But if defect is very severe, which means that aortic valve leaflets are staying open during the whole diastole, we have hollow diastolic. So, and it means that it's becoming pendiastolic, like this. This is second murmur in our numbering. So, this one was early diastolic, this is hollow diastolic. All other characteristics are the same. Decrescendo, everything, site of auscultation, so on and so on. Was clear?
Yes.
Diastolic murmurs, we are going to murmurs typical for mitral stenosis. So mid diastolic or late protodiastolic murmur. But in English it's mostly mid, so third murmur, mid diastolic murmur. You remember that S1 was loud usually in mitral stenosis. This is S1, this is S2. Okay, but my mistake, because I didn't leave a space. Next S1. Opening sample, which appears after S2 after 0.06 to 0.12 seconds. Remember, so it's like S2 plus this interval. And very often we can confuse it with S3, which also appears approximately there. And there we distinguish S1 is soft or loud. Here it is loud usually in mitral stenosis. Once more we'll speak about the intensity. While I'll tell you factors of influencing, I think during next lecture, just remind me. S1, S2, S1. Look, during fourth year, we'll not have time to speak about this. For cardiology, we should speak already about other heart disease and so on. And there, they are present, but this explanation in details, try to take maximal advantage. For example, up to now, I remember my teacher of propedeutics who taught me, not only me, us, these issues. Up to now I'm using this. Yes, maybe a bit updated, other sources and so on, but skeleton of the material is the same. So, why we have murmur? Now let's discuss. Mitral valve area, you know how much is in surface? Somebody knows? the mitral valve area, I mean surface, not site of auscultation, because the same abbreviation I'm using for this, is equal 4 to 6 centimeters in square. Theoretically, 3 and 9 is stenosis. But in reality, it starts to be apparent when it is less than 2, 1.5, 1, less than 1 critical stenosis. There, look what happens. Between left atrium and left ventricle appears very high transmitral pressure gradient. Alongside of two sides of mitral valve, pressure gradient is increased. Anyway, all valves work due to pressure gradient. For opening of mitral valve is enough up to 5 millimeters of pressure, from 0 to 5. This is the pressure gradient normally. In case of mitral stenosis, it may become, for example, up to 20. That's why we have opening stent, first of all, because under this high pressure, it is leading to overstretching of subvalvular apparatus, which is chordae tendineae and peptide muscles, and this opening is associated with sound production, which is abnormal. Normally, all valves open without producing any sound, silently. Now, this silence is impaired, we have opening stent. And this is what? S1, S2, OS. Quails written. S1 plus S2 plus OS. Quails written. Auscultatory, 3-component, triple written. Some authors also these murmurs are describing here, but classical Quails written is only sounds. S1, S2, OS. OS corresponds to the moment of opening of mitral valve. Now look, after opening from left atrium, blood should flow into the left ventricle. Basically, instead of 4 centimeters, it is 1. Narrowing in diameter, velocity increase, and turbulence, and murmur. So, murmur starts just after opening step. We have rapid and slow filling phases. Gradient decreases. Accordingly, yes, here is abnormally high gradient, but anyway, it is also decreased. And murmur decreases. So it's decrescendo. But when it is coming to aortic, to atrial systole, yes, we have rapid ventricular filling, slow atrial systole. In atrial systole, this turbulence once more is increased. This is presystolic murmur. Presystolic murmur. Why presystolic? Because S1 was systolic. Presystolic murmur. So number 4. This is number 3 murmur. This is 4. Very often these two are described together as mid-diastolic or late protodiastolic murmur with presystolic accentuation. Like its component, which is being accentuated. It's continuation of the murmur. That's why both are typical for mitral stenosis. Description: mid-diastolic murmur with presystolic accentuation. Site of auscultation is mitral valve area. It's not spread as a rule, in comparison with regurgitation. It's not spread. We listen only about the mitral valve area. And this one is loud. Intensity at first decreases, then increases, due to the above mentioned factors, not to repeat. Now look, mitral stenosis leads to a condition when left atrium is undergoing volume overload because less blood is flowing in diastole from left atrium to the left ventricle during each diastole. So during the time left atrium is enlarged. Enlarged left atrium is a good background for such an arrhythmia as atrial fibrillation. Atrial fibrillation, AFib. Atrial fibrillation is the most common arrhythmia in the world. What happens in atrial fibrillation? In atrial fibrillation, about arrhythmias, I have decided we'll speak next year. This year we'll speak only about ECG basics. ECG, normal waves, intervals, measurements, heart electrical axis, maximum hypertrophies, but not arrhythmias. Just ECG basics, that's the metaphor here. Now, fibrillation means that various groups of myofibrils of atria are depolarizing and contracting, but unsynchronized. like asynchronous contraction phase of ventricles. Something like this, instead of this. So this is effective atrial systole. It is lost. And it's very common condition. When mitral stenosis is complicated by atrial fibrillation, presystolic component F murmur disappears because we don't have systole, atrial systole. Accordingly, we cannot have a murmur. Diastole remains, but atrial systole is intact. Effective atrial systole is lost. Remember this. And by the way, atrial fibrillation itself is a very common cause of thromboembolic complications, because when atria is enlarged and we don't have effective circulation, especially if you remember, atria have ears, auricles. It is like out of circulation. It's a good background for clot formation. This clot from left atrium is passing into the left ventricle and may be spread through the systemic circulation. One of the shortest distances is brain, so we may stroke. Patients with mitral stenosis may die of stroke. Look from where to where. And it's not rare. Vice versa, it is very common issue. So these were main structural organic murmurs. We have functional murmurs. Yes, then. But before going to functional murmurs, today let's finish with two murmurs. It is murmur, extracardiac murmurs. Functionals we'll speak next time. Okay? Two murmurs are left, and you may rule. Murmur in PDA, patent ductus arteriosus. Arterial duct is connecting in the intrauterine period aorta with pulmonary trunk. By the moment of birth, or very soon after it, classically after the first cry of a baby, it should undergo occlusion, and afterwards it is remaining in the form of ligament. But if for some reasons it doesn't happen, today I don't want to speak about these reasons, there are a lot, appears a defect. Now we should understand blood flow is from where to where. Look, for example, schematically I'm writing, this is aorta, and this is pulmonary trunk. Between them is patent ductus arteriosus. Image you remember. If we'll pass from pulmonary trunk to aorta, aorta to pulmonary trunk, look, it is relatively narrow, small vessel. Anyway, we'll have turbulence while passing. Now let's understand how. For understanding how, we should know difference of pressures. So, in systole, pressure in aorta and pressure in pulmonary trunk, and diastole, pressure in aorta and in pulmonary trunk. In aorta, I'm taking average values. In children, it may be, of course, less. In aorta, how much is the systolic pressure? Who knows? Who knows? Maybe somebody knows. Huh? Look, logic, you're right. Logically 120 systolic blood pressure. Here should be higher. Okay, let's take 120. Systolic blood pressure in pulmonary artery is 30. So pulmonary artery, pressure in pulmonary artery is equal to 25 or 30. I'm telling you adult results. In children, it's less. I don't know in children, it's pediatrics or pediatric cardiology. 25 at rest, 30 on exertion. 26 already is considered to be pulmonary hypertension. Remember these values. There is mean, there is systolic, there is diastolic, systolic pressure. Now look, 120 30. In systole, we'll have from aorta to pulmonary trunk. Diastolic values in aorta it is 80. In pulmonary trunk, it's up approximately 10. So again, from aorta into the pulmonary trunk, which means that during both systole and diastole, we have continuous flow and thus murmur. It's a typical continuous murmur. Murmur behaves like this. Wait, right. Okay. If you're finished with this, then you want to go. Like this. It is S1. It is S2. It is next S1. So murmur behaves like this. Is increasing up to S2 and decreases up to next S1. Peak is on the level of S2. Wait. Oh. So it's crescendo, decrescendo murmur. Now, about the murmur characteristics. It's systolic, diastolic, continuous murmur. Holosystolic, holodiastolic. Intensity increases from S1 to S2. Peak is corresponding to S2, then decreases to the next S1. Site of auscultation. It is best heard over the jugular notch. Where is aorta? It's not. It's above the valves. Here are your valves, for example. Here is your valve. Here is your valve. It's above the valves. That's why here. Maybe posteriorly as well. It's resembling machine-produced murmur when we say machine. Machinery murmur. It's called machine-produced or machine-made murmur. Continuous murmur. By the way, I didn't want, but anyway, here is the lecture. Look. Continuous machinery murmur, patent ductus arteriosus. You see? Here is the case when even we may have 6 out of 6 murmur, because it's very without stethoscope. This is a congenital defect. Congenital defects are more likely to give high intensity. These are the rough defects. Holosystolic, they have written the word plateau rectangle shape. If you tell, it's okay. Yes, also in ventricular septic defect, but I didn't speak about this because it's either complication of MI or BSD is a part of tetralogy follow. So congenital defect, or maybe just BSD without follow. This is how they look like PCG, phonocardiography. And pericardial friction rub. Pericardial friction rub is due to dry pericarditis. How it appears? At first, let's speak about this. Then I'll show you something. Pericardial friction rub appears due to 2 circumstances. Normally, we have some fluid. Dear friends, I have a terrible headache. Please, 5 minutes. I think even 3. We'll finish. Now I can silently go out. It will make more noise. Background, somebody speaking. No. Where are my lectures? Cardiology lectures. Cardiology. In pericarditis, I'd like to show you this murmur. Okay. Where is it? Again, we came back to this. No, I don't want. pericardial friction rub. Pericardial friction rub appears when, in case of pericarditis, I didn't open it by the PowerPoint. This is pericardial segment. This. Here is visceral layer, here is pia layer. Between that there is ultrafiltrate, which is called pericardial fluid, up to 50 milliliters. It acts as a lubricant, and internal surface is smooth. If we have inflammation, normal level may be decreased in dry pericarditis, because in exudative, of course, fluid will be increased, or with diffusion. So it's without diffusion. Fluid decreases, permeability is increased, fibrinogen is coming out of the vessels and is forming fibrin deposits over the layers. And when they are contacting with each other, this non-smooth surface and lack of fluid, normal fluid, leads to pericardial friction rub. Pericardial friction rub may be systolic, may be diastolic. I'm not telling continuous, because look, we have three components: atrial or presystolic, ventricular systolic, and ventricular diastolic. Even presystolic is separated. So it's systolic, diastolic murmur, systolic dash diastolic murmur, which is heard over the chest, over the absolute cardiac dullness area, over the absolute cardiac dullness area, when stethoscope is firmly pressed against the chest. It's unstable murmur, so it may disappear, it may be changed with the position changes, patient's position changes. It is not spread. This you have done? Photo you take? Yes? We have absolute dullness area and relative dullness area apart, but percussion apart we are not passing. Just we know that below second intercostal space is located heart, from 50 to up to 50 intercostal space, on the left side normally. So there we are not doing auscultation, percussion of lungs, because resonant is replaced by cardiac dullness. But heart is located in chest, and partially it's in mediastinum. It's covered by lungs. So part which is covered by lungs, here is air. If we perform percussion, we have dull but with some resonance. It's relative dullness. Absolute dullness area is which is not covered by lungs. So pericardial friction rub is heard over the absolute cardiac dullness area. Is not spread and is resembling a sound which we get while walking on the snow, or when we are turning the page. Difficult to obtain. Okay. Like this. So what are left? Functional murmurs. Functionals may be innocent about this, I told you, the mechanism I tell, and maybe instantly functional. Instantly functional means that they are not related to septal defects, or they are not related to structural problems with the valves. In this case, they are due to what? They may be due to functional insufficiency, so functionally they are not properly closed, functional stenosis, and unusual starting position of leaflets before the closure. But next time remind me to speak about components, factors which have influence on sound intensity. The last thing, functional insufficiency, for example, may be if we have dilation of fibrous annulus. Fibrous annulus dilates, leaflets are separated. But leaflets under the microscope, on echocardiography, on autopsy, for example, if patient will die of car accident, are intact, which means are not affected. So problems with valve is absent. But something is wrong with their function. Why and how? Next time. If you have any questions, please you may ask. If